is Dr. K. Santan Gopal. Co-chairperson is Dr. Mayur Morikar. Co-convener Dr. Rajesh Prabhu V. and Dr. Hiranmoy Das. And myself, Dr. Shrutakiti Parida, is the moderator for this session. The duration for this session is 5 minutes. So let us all try to stick to time and help each other. So now the first presenter is Dr. Jaspreet Sukhija.
A very good morning to all of you. I'll be presenting my paper on the findings what we got when we did the genotyping of the patients with the Leber's hereditary optic neuropathy. Some of which is rare to find here. The patients are rare to find. The mutations are not, the positivity rate is quite less. So I'll just go through what we found. And so as we all know, it's a hereditary progressive bilateral optic neuropathy. Most of the time what happens is it's a sequential involvement, one eye followed by the other. And there's a male predominance because of probably the Y chromosome. Usually peaks in the second and the third decades. The literature says it's about 20 years of age. Because it's a papillomacular bundle involvement, it presents with central or centrocecal scotomas, abnormal color perceptions, and decreased contrast sensitivity. Now, the optic examination really depends when the patient presents. It could be just normal, could be hyperemic with some kind of a swollen disc. Peripapillary telangiectasic vessels are a quite diagnostic feature in the early phases. Or if they present late, they could have a temporal pallor or a total disc pallor. So the most common are the base pair mutations. What we find in these patients of LH1, these are that encode the proteins in the respiratory chains. And these are the ones which cause defects. So you have 3 types of mutations, the most common ones seen in 90% of the patients. It's 11778A, which really has a poor prognosis. Then you have 14484C, a much better prognosis, and a rare one, which is 3460A. Now, all these variants have been described in literature, but wherever you find, most of these studies, you have the first one, that is a 11778 mutation, what they find commonly. So of course, it was a retrospective study. We had patients who presented to a hospital with clinically suspected LH1. We did a detailed evaluation, including history of onset of symptoms, progression, family history, visual acuity testing on Snellen chart were done, visual field testing was done, pattern visual evoked potential was done, because of course we have to rule out other causes before diagnosing a patient of LH1. Genetic testing was then undertaken. So we had these patients, about 11 patients of the 31 clinically suspected LH1 patients. So of course we did not include the ones which were mutation negative. So we had 7 with the mutation of 14484. So the most common presentation was with this mutation and not with the second one, which is 11778, which most of the studies quote. And the third one was the 3460 mutation. So all patients with the 14484, that is the milder mutation, presented before 20 years of age, while the others presented later, while the mean age of presentation was 21.3 plus minus 4.7 years, which is in accordance with the literature. But in the ones with the milder mutation, the first one, this is 14484, presented before 20 years of age. So the clinical presentation was, most of them had bilateral involvement. One had ulinatal involvement, which subsequently progressed. The logMAR visual acuity ranged from 0.6 to 1.7. All had severely deranged color perception. Patients with the 14484 mutation, they had varied disc findings ranging from temporal disc pallor to hyperemic discs in 2 patients and completely unremarkable in another patients, whereas all other genetic mutations had a pale disc. And so 8 of these 11 patients had central cecal scotomas, and 2 with the 14484 had diffuse field depression, and 1 with this severe mutation had a bitemporal hemianopia. So we had a varied presentation of the visual field defects as well. Structural defects, 7 patients exhibited ganglion cell loss and RNFL thinning. So both of these were present in 7 patients, what we would expect if they present late. 3 patients had just GCL loss, but no RNFL thinning, and 1 patient did not show RNFL or the ganglion cell loss. So basically, they are patients who had an inactive but viable GCL. That is the thing to remember in these patients. All of them had decreased N75 and P100 on visual evoked potential. So we had a follow-up of 1 year, and four out of the 7 had progression of the disease with decrease in visual acuity, progression of the fields, 2 improved visual acuity. Obviously, these were the patients with 14484 mutation, and 1 remained stable. So, but the other ones who had a severer mutation were stable. They had decreased visual acuity at 1 year, but that did not progress, but that was a severe decrease in visual acuity. So our limitation of the study was a small sample size. Out of 31, we could get just positivity in 11 patients. The follow-up was just 1 year, so that is another limitation. So I'd like to conclude here that there's a genetic and clinical variability. The most common mutation was 14484 as compared to other studies, and they had a positive family history as well. So what I want to like to say here is that there is inactive but viable GCLs in a milder disease, which probably one can give, you can say the IDBNON which is coming up, probably you can give a trial of that for these patients who probably can improve, have an improvement in their visual acuity. So my take-home message is that our profile is a bit different as compared to what is found. We have milder mutations. Why not give a trial of the medicine which is available in the market and prevent further visual loss?
Okay. Okay, thank you, Jaspreet. Pretty straightforward cases. Nothing much to write home about.
That's exactly, I mean, it's just the message I wanted to give that yes, the mutation profile is different. Don't just leave it, I mean, treat them.
Okay, good. Thank you.
Thank you, Dr. Jaspreet. The next presenter is Dr. P. Savitri.
Just announce next speaker to be present here and be released.
The next speaker on the line is Dr. Gaurav Sachdev. Please be ready after this.
Yeah, please.
Good morning, one and all. I'm going to talk about a case series of ophthalmic association and optic nerve aplasia. So it's not moving. Optic nerve aplasia is extremely a rare congenital optic nerve anomaly, presents with the absence of optic nerve head, retinal vessels, retinal ganglion cells, and optic nerve fibers. The exact estimation of optic nerve aplasia is not known, or it is underestimated due to media haze obscuring the visualization, or lack of imaging, or focus on other obvious findings. So the associations are not highlighted. The diagnosis of congenital optic nerve aplasia is highly significant due to its genetic and systemic implications. Our study is a retrospective study which includes patients with microcornea or sclerocornea with suspected posterior segment pathology, referred from pediatric clinic for fundus evaluation or imaging, or patients with clinical or imaging findings suggestive of optic nerve aplasia. Detailed history of consanguinity and family history, visual acuity and visual behavior were assessed, anterior segment and posterior segment examination with B-scan were done. All examinations were done without general anesthesia. Our results are 7 eyes of 4 babies presented between 3 months to 4 years of age. 3 eyes of 2 patients had no perception of light and 1 eye had perception of light. Younger patients' vision couldn't be assessed. 6 out of 7 eye had microcornea, out of which 4 with opacification, and clear cornea was noted in 2 eyes of 2 babies. Along with that, 1 eye had persistent pupillary membrane, and pupillary reflex could not be elicited due to opaque media or poor cooperation. No visualization of the posterior segment is noted in 5 eyes, and absent optic disc noted in 2 eyes. MRI showed optic nerve hypoplasia or aplasia, and it was confirmed in all 7 cases. Along with that, 2 eyes of 1 baby had a colobomatous cyst in the eye, and 2 out of 4 babies had chiasmal aplasia. B-scan of 7 eye revealed microphthalmus and small rudimentary or absent optic nerve shadow. Eyes with no view had crumpled up retina, total closed funnel RD, stalk-like structure. Along with that, absence of lens in 2 eyes of 1 baby, and dystrophic calcification of ocular codes was noted in 1, and specks of calcification was noted in 1. Final diagnosis in the presence of 3 bilateral and 1 unilateral hypoplasia or aplasia of optic nerve was done. Genetic testing was offered for all 4 patients, where 2 babies had 1 balanced chromosomal translocation and another one with PIT-X3 mutation. Our case 1 had microcornea with scarring with shallow anterior chamber in the right eye, and left eye had persistent pupillary membrane with no view of the fundus, where MRI showed optic nerve aplasia. And case 2, both they had microphthalmus and corneal scarring with no view of the fundus. MRI showed extreme microphthalmus with multiple colobomatous cysts and hypoplasia of the optic nerve and chiasma. Our third case showed normal right eye and left eye had no fixation of light and microcornea with corneal scarring, and fundus showed absent disc and vessels with colobomatous changes. MRI showed unilateral optic nerve aplasia in the left eye with thinned out extraocular muscles. Our case 4 showed mutation in PIT X3 mutation, and this is the summary of a largest case series of optic nerve aplasia done by Safran et al., in which is comparable with our study, which shows most common presentation is microphthalmia or microcornea, and anterior segment showed persistent pupillary membrane. Posterior segment showed absent optic nerve, retinal dysplasia, persistent fetal vasculature, retinal atrophy, and chorioretinal coloboma. MRI showed absent optic nerve and chiasma. Along with that, absent lens and balanced chromosomal translocation and PIT X3 mutation variant was diagnosed in our case series, and it happened to be the second largest case series to best of our knowledge. To conclude, the diagnosis of ONA can be made with high index of suspicion when associations like microcornea or with or without opacification, other developmental anterior segment anomalies like persistent pupillary membrane, closed funnel retinal detachment, dysplastic retina, and persistent fetal vasculature. Microphthalmic eye prompts imaging with B-scan or MRI for the optic nerve status to rule out associated CNS anomalies. Isolated ONA without systemic abnormalities require early initiation of rehabilitation according to their age to reduce the morbidity. Thank you.
It was a nice presentation. I had only one doubt.
Yes, ma'am.
As you told, there were no systemic ailments in this babies. So why didn't you do the examination under anesthesia? Because all your patients were very small, like 7 months, 6 months old.
Yes,
so why didn't you use the general anesthesia for examination? Because it would have been very easy for you to examine the
No,
child.
all the examination we did, and babies were comfortable without general anesthesia only, ma'am. So we didn't have an option to do it.
Okay.
We were able to do the examination without general anesthesia only.
Okay. Even the neuroimaging you did without anesthesia?
Neuroimaging, we didn't do it here. It was done outside, ma'am.
Okay.
The optic nerve hypoplasia, is it primarily a retinal ganglion cell maldevelopment
Yes, sir.
rather than hypoplasia of the optic nerve?
It is a retinal ganglion cell development, sir.
So, if the retinal ganglion cells are maldeveloped, automatically the optic nerve gets maldeveloped.
Yes.
So, the primary problem is in the ganglion
Ganglion
cells,
cell.
not necessarily, because optic nerve is, after all, it's an axon. The cell body of the axon is in the ganglion cell layer. So, if the cell body doesn't develop, the axon doesn't develop. So, it's a misnomer to keep saying optic nerve aplasia, hypoplasia. You should say ganglion cell abnormality.
Yes.
Correct?
Yes, sir.
So, to prove that, you should have done OCT.
Babies are very young to do an OCT, or it's like 7 months old and 3 months or 4 years. Like that only we had patients, sir. And the media view is not there in most of the babies. Media clarity was not there.
Okay, good.
Thank you.
Thank you. Next presenter ready?
Nice study. The next presenter is Dr. Gaurav Sasdev. Okay. Dr. Gaurav has not uploaded the PPT. So the next one is Dr. Neena R.
So very warm good morning to one and all. No financial interest. So as we know, when light falls on the retina, it's first picked up by the photoreceptors, then it goes to the bipolar cells, then the retinal ganglion cells, and from there, the axons of the retinal ganglion cells form the optic nerve, and from there it goes to the optic chiasma, and then to the tract, then finally relays at the lateral geniculate body, goes to the optic radiation and to the occipital lobe of the visual cortex, and that's where the vision is processed. So we know that the retinal ganglion cells are the only output neurons from the retina, and a lesion anywhere along this pathway of the retinal ganglion cells can result in cell death and can be picked up in the retina with the OCT. So this is the picture of the course of the retinal ganglion cells across the retina, maximum concentration in the perifoveal region with absence at the fovea itself. And this is a beautiful picture of the OCT showing the quantification of the retinal layers. So the aim of a study was to see if you are able to understand the pattern, if you are able to correlate the macular ganglion cell loss as seen on OCT and correlate it with the neuro-ophthalmic findings and the visual field changes. And this was done in patients coming to a tertiary eye care center with neuro-ophthalmic disease. So we picked up retrospectively, we picked up 5 cases of optic neuritis, non-arthritic anterior ischemic optic neuropathy, pituitary macroadenoma, idiopathic intracranial hypertension, and PC infarct, and try to correlate the clinical findings with the investigations, neuroimaging, and the macular GCN analysis as done on SD-OCT with a Heidelberg machine. So first case was an 18-year-old college student who came to us with sudden onset of blurred vision left eye, 645 N36 with RAPD in the left eye. And you can see in the fundus, she had a hyperemic blurred disc in the left eye. The VEP showed a reduced amplitude and a prolonged latency in the left eye. And the visual fields showed a dense nasal scotoma and some inferotemporal visual field defects. The OCT of the RNFL showed some non-specific temporal thinning, but look at the GCL. It showed a corresponding temporal and supranasal thinning, corresponding exactly to the field defects. And her diagnosis of optic neuritis was confirmed on the MRI, showing a thickened and hyperintense optic nerve with post-contrast enhancement. The second case is that of a 55-year-old man with labile hypertension, defective vision, N36, near vision with poor distant vision, RPD again, and the disc showing a feature suggestive of non-arthritic anterior ischemic optic neuropathy. Look at the visual fields, an inferior altitudinal defect. See the GCL, superior GCL thinning corresponding exactly to the altitudinal defect, whereas the RNFL just showed an inferotemporal edema, which was misleading. Coming to the third case, a 45-year-old lady with gradually progressive vision loss. Everything was normal, vision, anterior segment, fundus, but bitemporal hemianopia. And look at the GCL, binasal GCL thinning corresponding exactly to the bitemporal hemianopia, whereas the RNFL did not show any specific changes, and she had a stellar mass compressing the chiasm. The fourth case is the 32-year-old housewife with chronic headache. Vision was normal, but fundus showed papilledema, established papilledema, RNFL edema on OCT. Fields were normal, GCL was normal. Now what's the role of GCL here? When you give treatment for idiopathic intracranial hypertension, the edema comes down. We are in a doubt whether it's due to progressive optic atrophy happening or due to the edema actually decreasing. Monitor the GCL with this. A stable GCL assures you that patient is improving clinically. Now the last case is a 68-year-old hypertensive and diabetic with recent complaints of hitting objects on the left visual field. Vision was normal, fundus was also essentially normal, but look at the visual fields, left homonymous hemianopia, and look at the GCL, exact right-sided nasal thinning of the GCL mapped on OCT corresponding to the visual field effect, whereas RNFL was within normal limits. And as expected, he had a right-sided infarction of the parieto-occipital cortex, which was responsible for his hemianopia. So what I would like to point out is that MGCN analysis has a better correlation with the visual field changes than with the PPRNFL analysis, and this was shown in many studies by many previous authors. And to conclude, MGCL may have a direct correlation to the vision field loss. It's an effective tool in diagnosing, monitoring, prognosticating neuro-ophthalmic conditions, especially when visual fields are not feasible due to low vision or poor cooperation. Thank you very much.
Thank you, Dr. Neena.
Okay, thanks.
So the next presenter is Dr. Pinky Patel. Are you there? Yeah. After this, Dr. Monica Barik, please be ready. Dr. Monica Barik, the next one.
Good morning, everyone. Myself, Dr. Pinky Patel. Good morning, everyone. Myself, Dr. Pinky Patel. My topic is to study clinical presentation and visual outcome of tubercular optic neuropathy. Introduction. Tuberculosis is an infection caused by the Mycobacterium tuberculosis and is most commonly occurred by the inhalational route by which infectious agent enter in the lungs and primary infection is stabilized. The hematogenous or lymphatic spread can result in involvement of the other side. Ocular involvement is reported 6.8% of patients with pulmonary tuberculosis. Tuberculous optic neuropathy may follow infection with Mycobacterium tuberculosis or administration of the Bacillus calmette carrying vaccination or as a result of hypersensitivity reaction. The report of clinical manifestation of tuberculosis disease increase in the literature. Disease may reflect direct infection or an associated hypersensitivity reaction. The manifestation of tubercular optic neuropathy comprises of optic neuritis, retrobulbar neuritis, papillitis, neuroretinitis, papilloedema. My aim is to describe clinical presentation and ocular outcome of tubercular optic neuropathy in tertiary eye care center. Material method, retrospective hospital-based observational study, duration 1 year, in tertiary eye care center, Jharkhand. 9 cases associated with tubercular optic neuropathy who present Department of Ophthalmology. Informed consent was obtained from each patient prior to enrollment in the study. Inclusion criteria, all patients with tubercular optic neuropathy during study of 1 year were included. Examination included external examination, best corrective visual acuity, near vision chart, color vision, extraocular involvement, pupillary reaction, anterior segment examination by slit lamp, IOP, dilated fundus examination by direct and indirect ophthalmoscopy. Renal liver function test, serum electrolyte, blood sugar, urine routine examination, BDRL, torch profile, HIV, chest X-ray were done. Montex tests were done to look for tubercular etiology, which turned out to be strongly positive. Suspecting tubercular meningitis, lumbar puncture done. CSF in which lymphocytosis, low glucose content and high protein and ZN staining positive for acid fast bacilli. OCT examination for thickening of retinal nerve fiber, Humphrey visual field done for visual field defect and MRI orbit and brain was if required. TB was confirmed by identification of acid fast bacilli in 1 case and presumed in 8 cases on the basis of positive PPD or gamma interference release test. For drug ATT was given 55.56% and ATT with adjuvant systemic and topical steroid was given 44.4% of our patient. But all patients who agree to treatment and continue in follow-up monitor closely for deterioration in color vision, visual acuity. Visual field following initial improvement may indicate drug toxicity under pulmonology consultant. In addition, pyridoxine is routinely combined with isoniazid to protect against peripheral neuropathy. Result, out of 9 cases, 6 male, 3 female, 7 patients unilateral, 2 patients are bilateral. Presenting symptom, decreased vision, pain, visual field loss and other. Sign uveitis was additional ocular morbidity in 88.7% of the eye. Final visual outcome, 612 to 624 at present 2 patients, on ATT 3 patients, on ATT plus corticosteroid 3 patients. Visual acuity 636 to 660, at present 3 patients, on ATT 2 patients and on ATT plus corticosteroid 1 patient. Visual acuity less than 660, 4 patients. Conclusion, in this study out of 9 cases with tubercular optic neuropathy, the disease was typically unilateral and the majority of patients presented with painless decreased vision and papillitis. Ocular manifestations should be watched for in all patients of both pulmonary and extrapulmonary tuberculosis. No significant difference in outcome was observed in patients treated concomitantly with ATT drug and steroid versus anti-tuberculosis drug alone. Pre-ophthalmic workup and regular ophthalmology follow-up when ATT started. Never hesitate to do neuroimaging to confirm the diagnosis and plan for management. Discussion, optic neuropathy in tuberculosis occur due to tubercular perineuritis, papilloedema, consecutive optic atrophy due to raised intracranial tension, intraotitis of optic nerve, toxic neuritis due to drug. Visual outcome were good and were not impacted by the use of corticosteroid therapy. Intraocular tuberculosis can be primary when the entry of bacillus is at eye level. Secondary in case it appears as a result of hematogenous dissemination from distance and nearby focal point. Ocular involvement occurs approximately 1 to 2% of tubercular patients. It was usually distributed to other infection. The patient must be counseled about possible impact on vision and symptoms they should watch for presence of which is imperative to see the ophthalmologist. A clinical diagnosis of ocular tuberculosis is difficult due to a varied presentation and other indistinguishable for other case of uveitis. These are my references. Thank you, sir.
Okay, thank you, Dr. Pinky. I had one doubt. In which cases did you give like this systemic and topical steroids, and why? You were
Ma'am?
telling that you gave adjuvant systemic and topical steroids in addition to ATT. So in which cases you did give this?
Ma'am, in tubercular patient,
In tubercular patients, you are giving ATT. Is there any need for additional adjuvant steroids, systemic as well topical? It's not needed in all patients. Why you have given in certain patients? You are telling that you have given in very few patients adjuvant steroids, systemic as well as topical. So why did you give? And with which patients?
See, I was going to ask the same question in the other way as why it was not given in all patients. See, because you are calling this tubercular perineuritis. Okay. There is one thing about it. You are saying 85% of the patients came as painless loss of vision.
जी sir.
And at one point in the presentation, you are saying majority of these patients were uveitis. So
Yes.
then that didn't add up somehow.
Yeah, actually this is not matching. Like 88.7% you are telling present with uveitis. So you're giving the steroids for the uveitis.
How did it? And how did you differentiate between whether it is the optic nerve involvement is because of drugs or because of the disease per se? So you have mentioned that a few drugs can cause neurotoxicity. So
Yes, sir.
whether it is caused because of the tuberculosis disease itself or is because of the drug toxicity, is there any way of finding the difference?
Sir, color vision.
It's a presumptive diagnosis. You are presuming that tubercular is the etiology, but it's not
जी sir.
necessarily always correct. See, you have to distinguish between presumptive and causative phenomena. Presumptive is your presumption. It's not necessarily accurate. Whereas causative is where it is the cause. If it is causative, the treatment of the cause cures the condition. If it is presumptive, nothing happens. Okay. Never mind.
And also when you are telling that you had done the LP, but did any patient present with tubercular meningitis, or in all patients you did the LP?
Sorry.
Thank you.
Thank you. The next presenter is Dr. Monica Barik.
Good morning, everyone. I'm going to present on topic or study on the clinical profile of toxic and nutritional optic neuropathy. The aim of the study is to evaluate the etiology and clinical profile of the patients diagnosed with toxic and nutritional optic neuropathy. Nutritional deficiency may also be the cause of genuine optic neuropathy, which is sometimes associated with involvement of peripheral nervous system. With the exception of vitamin B12, no specific nutrient deficiency has been conclusively proved to cause the optic neuropathy in humans. The pathophysiological mechanisms which are involved in toxic and nutritional optic neuropathies affect biochemical pathways involving the cell energetic production, correction of oxidative stress, and quenching of free radicals causing papillomacular bundle damage. In the current scenario, the treatment is limited to the intensive use of vitamins with variable results. As the entirety is mostly a disease of exclusion with a blanket cover diagnosis, promptly probing into the etiology with directional history, clinical examination, and specific investigations, the underlying cause can be identified and addressed for the improving the morbidity in the long run. The study population was proven cases of toxic and nutritional optic neuropathy attending the OPDs. It was a prospective observational study. The criteria which was included were all the clinically proven cases of nutritional and toxic optic neuropathy, and the exclusion criteria were the patients with history of trauma or any ocular pathology like corneal dystrophy or diabetic retinopathy or glaucoma. Results in analysis. In my study, the number of patients were total taken to be 45, among which the number of males were found to be 69% and females were about 31%. The age distribution was commonly found between 31 to 40 years of age. The number of cases diagnosed with toxic optic neuropathy was 39, and number of cases with nutritional optic neuropathy was found to be 4. And the cases diagnosed with both toxic and nutritional optic neuropathy was found to be 2. The number of cases diagnosed with toxic optic neuropathy due to cause of alcohol was 2, and due to tobacco was 13, and mix of both tobacco and alcohol was found to be 16, and due to drug like anti-tubercular drug was found to be 8. Number of cases diagnosed with vitamin B12 deficiency in my study was 1, and due to folate deficiency was found to be 1. The number of cases diagnosed with nutritional optic neuropathy due to vitamin B12 deficiency was 3, and the number of cases diagnosed with nutritional optic neuropathy due to folate deficiency was 1, among which the nutritional deficient optic neuropathy vitamin B12 seems to be the most common cause. When the color vision, the defective vision was found to be earlier 78% and normal patient was 22, but after the 3rd month of follow-up, it was been improved, and follow-up was about 29% in normal patient and defective was among 71%. The same central field, when it was done, the p-value was found to be less than 0.05, which was significant difference in both central field and between the follow-up and the baseline. Among the defective central field, the centrocecal scotoma was accountable the maximum, followed by the central scotoma, and the improvement was also seen in patients suffering from centrocecal scotoma, accounting about 3 months. 3 among the 7 was affected. The findings in the fundus was found to be hyperemia, disc, and temporal pallor. Of the above finding, the temporal pallor was noted with the most in finding the study population. The fundus showing the both temporal pallor in both eyes. The hyperemia and temporal pallor have been seen to resolve over the 3 months, following by cessation and toxins and nutritional improvement. Conclusion: males are commonly study population affected. Toxic optic neuropathy overruled nutritional optic neuropathy, and hence early effective drug withdrawal shows prompt relief. A section of the study group had nutritional counterpart deficiency when suffering from toxic optic neuropathy. These patients have to be identified, and adequate specific nutritional supplements have to be given in addition to cessation of the offending agents to address the pathology. For more specifically, vitamin B12 deficiency optic neuropathy was reported more preceding folate deficiency as per our study. Visual acuity, color vision, central field, and fundus changes have to be monitored periodically once in 3 months to evaluate the effective treatment strategies. Centrocecal scotoma was found in most of the affected patients with temporal pallor taking overhaul. Hence, the changes have to be keenly looked in for the patient evaluation. For the nutritional compliance with these patients is a major challenge which has to be overcome with emphasis on its importance on follow-up. Thank you.
Was there a change in the symptoms, reversal of symptoms or fundus changes once you supplement nutrition in cases of nutritional neuritis, and when you stop the toxic substances?
So the changes were not that seen, but yeah, the temporal pallor and all was not, after 3 months of follow-up, it was not that
there was no reversal changes. Symptom-wise?
Symptom-wise, sir, the symptoms were reducing. With management of nutritional supplements and all, it was improving.
In addition to the withdrawal of the offending drug, did you prescribe any other nutritional supplements in patients who are having this toxic optic neuropathy?
Ma'am, methylcobalamin.
By which route?
Ma'am?
By which route? What was the route of delivery of methylcobalamin? Whether you were giving it intramuscularly or whether you were giving oral supplements, and for how much duration?
Ma'am, first we gave intramuscularly, then orally. After that, 3 months of follow-up, then orally was given.
In addition to that, any other supplements? You need to know the mechanism, okay, how it does the chelation. So accordingly, you have to also supplement zinc and others. Okay, thank you. So the last presenter is Dr. Shovita Shauravi Ratha.
Good morning, everybody. At the outset, thanks Team AIOC for giving me this opportunity. So let me discuss the clinical profile and outcomes of pediatric ocular myasthenia gravis presenting to our institute. With this 7.5-year-old male child who came to us where his parents complained that he has drooping of eyelids since 1 month. They also told that there was a diurnal variation. On examination, visual acuity was 6.6 N6, but as we see, there was acquired ptosis which has developed 1 month ago. There is presence of lid crease with PFH being 7 millimeters and MRD1 2 millimeters in both the eyes. On further fatigue test, it was positive, and eyes test was also positive. On ocular motility examination, we see elevation limitation in both the eyes, left more than the right. However, rest of the ocular movements were normal. Serum ACH receptor antibody and MRI was requested, and on And in the OT next day, a neostigmine test was done, which was normal. HRCT thorax was also asked, which ruled out any thymoma or thymic hyperplasia. With this clinical findings and ancillary tests and laboratory diagnosis of juvenile myasthenia gravis was made, the patient was started on oral pyridostigmine 30 mg thrice daily for a period of 6 months. We have been following up this patient now for a period of 1 year and has been stable with no recurrence or no onset of systemic symptoms. There has been improvement in motility and deviation. So 1 to 5 cases per million of JMG in children less than 18 years present per year, which is approximately 10 to 15% of all cases of myasthenia gravis, and 15% of all patients of myasthenia have isolated ocular involvement as the only manifestation. However, is there a literature in India stating how is pediatric myasthenia gravis presenting? Oh my God, it's not there. And to this brings us to our study where we wanted to study the presenting signs, therapeutic interventions, and clinical outcomes of OMG in a pediatric age group. The study period was from April 2021 to 23 of February. A retrospective case analysis was done, and all those children who had a follow-up period of 6 months were taken into consideration, who presented with ptosis, extraocular motility limitation, diplopia, with clinical evaluation corroborated with the ancillary test. We excluded those who had congenital myasthenia, any systemic associations, and neurological lesions on imaging. This was a diagnostic criteria which was initially given by Cooper Smith et al., followed up by Stacy Pinellas et al. In her paper, and we did follow this, where the criteria is ptosis and extraocular motility. One of them should be present, where a fatigue test can be positive with no pupillary abnormality except from a prior ocular disease like surgery or physiologic anisocoria. One of the ancillary tests need to be positive: fatigability, recovery after test, edrophonium, bar neostigmine test, which we commonly do nowadays, abnormal RNS or abnormal acetylcholine receptor binding antibody level, age at presentation between 1 to 18 years with the absence of generalized symptoms. And we classified these patients based on their improvement, whether they recovered, where there was improvement in ptosis and motility, partly recovered, either of them improved, refractory, no improvement after 3 months, recurrent within 3 months after stopping treatment if they recurred. So treatment was started in all our children because either ptosis or ophthalmoplegia or strabismus in children are potentially amblyogenic. So we started them on oral pyridostigmine 2 to 4 mg per kg body with no clinical improvement or worsening. They were added on oral steroids. If refractory, a detailed re-evaluation was done. After an oculoplasty, opinion was also sought, and recurrent cases, immunomodulators was added in consultation with a neurologist. Our results are there were similar number of male and females. The age of onset was slightly older, 8.1 plus minus 4.9 years, with an average follow-up of 6 months. Most common presenting symptom was ptosis, with clinical tests being positive in majority of them, in more than 50%, and most of them responded to pyridostigmine. On ocular motility, it was limitation of elevation which was more common than the other motility problems. Coming on to investigations and the test, the Cogan-led sign, the Simpson size test, was positive in 67%, and ACH receptor antibody was only positive in 28.6%. None of them had brain or thymoma, and RNS was not done in any of our patients. The treatment given was pyridostigmine alone, to which majority of them resolved and responded, and then a steroid was added if they didn't respond, and only 3 of them needed immunomodulators. Thus, juvenile ocular myasthenia is a clinically distinct entity in relation to adults. It's not the mini pediatric, it's not the miniature of the adult variant. Early suspicion and prompt management is necessary in all to know a complete recovery. Oral pyridostigmine can be restarted as primary modality with add-on steroids, though rare chances of generalization, a regular follow-up, and careful history taking is essential. So what's there in literature? Peripubertal age group of ocular myasthenia generally presents 5 years of age. In West, it is usually less than 5 years, with more preponderance in females. What we found was a marginal older, not pubertal, but between prepubertal and pubertal age group. Majority of them had equal predilection. Chances to generalization is less as compared to adults, which we did find in our time also. Respond to oral steroids and pyridostigmine is there in literature where they start both together, whereas we found more response with pyridostigmine only. Ptosis and stabilization we had comparable result. Thank you.
Thank you, Dr. Sovita. I had one question. If the patient is having only ptosis, we should start on pyridostigmine only. But if the patient is having ptosis along with external ophthalmoplegia and this strabismus. So it's better to start pyridostigmine along with the steroids.
That's the conventional teaching, and we
Yeah.
did that. We were doing that, but we deferred here. So in children, we did only with pyridostigmine, and majority of them resolved. If by 1 or 6 weeks follow-up, still we added on pyridostigmine elevated dose, they didn't improve, then we added on steroids.
Okay.
That's how we differ. The only difference between us, except for the age and demography, little.
Okay.
Did any of your patients been started on pyridostigmine empirically without just clinical suspicions with all other
Like
tests
a
negative?
therapeutic trial, sir?
Yeah.
No.
It's all proven
Yeah,
test.
most of them had symptoms. We didn't do that.
Okay. Thank you, Dr. Sovita. So this is the end of the season. All of the participants almost stick to the time. So a big thank you to all of you so that we could end the session in time.
Good, one small advice to the youngsters who are presenting. Do not include too much information in a slide. You can photocopy the entire Kansky book and put it there on the slide. It doesn't help in understanding, putting across your view to others. So stick to 3 or 4 salient features per slide. And if it is 5 minutes talk, you present about 10 slides or not more than 10 slides. I've seen many people 5 minutes, 25 slides, 35 slides will be there and lot of slides will be left unpresented. That doesn't convey a good impression while assessing the free paper. Since it's a free paper, you must stick to certain rules. One is time. 2, less number of slides. 3, less number of points per each slide is all advice I give you. But you all have done a good job. Thank you very much.